Next speaker is Professor Richard Baum. He's a specialist in the theranostic therapy. Okay.
Okay, and I am Dr. Yu Huang from Ku Foundation Sunshine Cancer Center, Taipei. And it's my greatest pleasure to introduce Professor Richard Baum, the president of the International Centers for Precision Oncology Academy and the chairman of the Kuranostiken Wiesbaden, Frankfurt in Germany. Professor Baum is truly a pioneer, and in my opinion, is the father of the modern theranostics, the one who truly brought this concept from vision to clinical reality through his pioneering work from Germany's first PRRT in 1997 to the world's first lutetium plasma therapy in 2013. He has shaped the global landscape of nuclear medicine. And his leadership continues to guide our field's transformation toward radiomolecular medicine. This is a new era where imaging and therapy are seamlessly united together for precision oncology. I believe we will all learn a great deal from his talk today and see the bright future and compassionate future of nuclear medicine unfolding before us. So please join me in welcoming Professor Baum.
Thank you very much, Dr. Yu, for your very kind words, and I would like to thank the organizers and especially our President Wang for inviting me. It's my fourth time here in Taiwan, and I'm very happy to see also a number of patients sitting here, which have been treated at my previous center in Bad Berka and at my center in Wiesbaden now before Pluvicto was approved here in Taiwan, which was also the topic of my first journey which I made. So I will speak about prostate cancer today, and a topic which might be very difficult, namely, will cure become possible? Because up to now we are achieving mainly partial remissions. So these are my disclosures. I have no conflict of interest, except that I'm still very much in love with radiolabeled molecules after 40 years. So theranostics is, and this is how I defined it already at the first World Congress, a diagnostic tool to identify the right therapeutic approach for a specific disease, or in short, see it, treat it. The term theranostics was first coined by John Funkhauser, who was the CEO of Pharmanetics in 1998. Actually, for the Herceptin test, it has nothing to do with nuclear medicine at that time, coinciding with the emergence of the personalized medicine concept. Regarding radioisotopes, and this is very interesting for you, Casey, I mean, you know it certainly, the term theragnostics, introducing the G from gnosis, a Greek word on knowledge, was later introduced by Suresh Srivastava at Brookhaven National Laboratory. So BNL was leading the way in many developments. And the first Theranostics World Congress, or W2C, was held 2011 in the little city of Bad Berka, attracting over 400 participants from 56 countries. The seventh edition took place last year in March 2024, and I will invite you at the end to the next World Congress. And the most well-established and long-standing application, of course, is radioiodine therapy, which is also being used here in Taiwan for decades now. So radiomolecular precision medicine, this is how I call personally nuclear medicine, because nuclear causes in many patients and the public, you know, some worries about danger and risks, and they think of atomic bombs and all other things when they hear nuclear, but not about medicine use. So I prefer the term radiomolecular precision medicine, or radiomolecular medicine is the right treatment for the right patient at the right time. And in nuclear medicine or radiomolecular, we have to add at the right dosage, right? No, so we are no longer targeting a disease, but rather the specific tumor of the individual patient, which is part of the personalized health care, which extends the concept of precision medicine by encompassing all aspects of patient care at an individual level, from the first signs of disease to full recovery. And this includes not only physicians, relatives, nurse, technologists, patients, of course, and even environmental influences. So radiomolecular precision oncology needs molecular imaging, as also stressed by Casey Cutler. That means we need PET-CT, PET-MR to define metabolism and molecular biology, the targets on the tumor cells. And we need also CT-MR for defining structure and getting a more precise localization of the lesions. Then nowadays, I have to mention genetics, specifically next generation sequencing, which we are doing now or beginning of next year by whole genome sequencing, which was several $100,000 a few decades ago when it was invented by Craig Venter, and has come down now to a few $100, and the machine can give you a diagnosis or a whole genome sequencing within a few hours. So this will become extremely important also for radiomolecular nuclear medicine, because it can be combined, for example, for screening with FAP, total body PET, and so on. And we are already doing this. Then we, of course, have liquid biopsies and circulating gene transcripts like the NET test, which can be also important for giving you the indication for molecular imaging. And on the other side, we have what I call not AI, but computational precision oncology. It's not artificial at all. So it involves the patient with a family history, molecular genetics, the environment, demographics, and many other factors. And we can use this IBM or intelligence-based medicine for eye theranostics, for intelligent theranostics. For example, doing automated PET-CT analysis within 20, 30 seconds, we are now able to get a very precise molecular tumor volume, especially when we are using this new super fast total body PET-CT, which can create an image, a very detailed image in 1 or 2 seconds of time. So all this together brings us to personalized medicine, which allows us better patient selection for therapy, earlier determination of treatment response, follow-up, early diagnosis, risk assessment, which unfortunately I cannot cover in this lecture, but it's a very, very important part, especially if it comes to PSMA and prostate cancer. Just recently, there have been a number of papers showing how predictive a simple PSMA PET-CT can be for the course of the disease. And as I mentioned, epidemiology and even preventive medicine will become our task for the future. You all know, hopefully, how theranostic works. It works according to the key lock principle. So we have our targets on the tumor cell. If they are G protein-coupled receptors like SSTR or CXCR4, can be enzymes like PSMA or carboanhydrase 9 and many others now explored. Or it can be in the tumor microenvironment like cancer-associated fibroblast or the good old tumor antigens like CEA, CD20 and so on, which might play a more important role again in the future, or transporters like, for example, amino acids or MIBG. And then we have the key, which fits in the lock and carries a linker, which is actually carrying the, or bringing the chelator. And the chelator is a little cage, so to say, which can keep the reporting unit for imaging like gallium-68 or scandium you have heard of, or other metallic radioisotopes, or halogens like F18, which can be directly labeled, or technetium-99m, which can also play an important role if it comes to PSMA imaging, because it's probably less expensive to use SPECT-CT, and for follow-up in many situations, a SPECT-CT, a good SPECT-CT might be enough. And of course, it carries a cytotoxic unit. You heard about lutetium, actinium, and lead already by Casey, and also for imaging, I would like to stress here terbium, for treatment, I would like to stress here terbium-161, which I will cover a little bit more in detail. You have seen this already. There is a now logarithmic growth of the market after the approval of lutetium dotatate for neuroendocrine tumors in 2018, and the FDA approval for PSMA in 2022. And PSMA, I would call the target of the maybe last decade. I mean, it's still the target, of course, we are using every day, but there are, meanwhile, probably more exciting targets from a clinical point of view, which is mainly FAP, but PSMA for at least 1 decade was the target. And it's a cell surface enzyme that's continually internalized. It has, and this is often forgotten, glutamate carboxypeptidate 2 activity and also folate hydrolase activity. So why are you seeing the small bowel on your PET-CT images, right? It's a folate hydrolase activity which you see. And interestingly, PSMA expression is actually mostly in higher grade tumors, in metastatic disease, and in hormone refractory cancer. So Gleason 3 tumors do hardly express any PSMA. But Gleason 9 or 10, 4 or 5 tumors, they in 100% nearly express PSMA. And that's something very clinically important. As higher the PSMA expression, as more aggressive is a tumor, and it's also present in neovascular, what we, for example, see in kidney or renal cell cancer. Now, this is an image which was given to me by Martin Pomper, who I call the father of PSMA. And it shows actually that Marty already had in 1987 interest in PSMA, not really called PSMA at that time, but it was the neuropeptidase and acidylated alpha-linked acidic dipeptidase, nice word to remember, it's called nadalase or naadalase, and the naadalase actually is PSMA. They are identical, right? So in the brain, there are the same mechanism taking place like in prostate cancer, where you have the activity of the PSMA as an enzyme. And these are, again, courtesy of Martin Pomper, showing you the glutamate activity in the brain and the polyglutamate folate hydrolytic activity actually in the small bowel, which finally led to the development of imaging compounds with fluor or with iodine. So in some way, I will not discuss the details. The PSMA went to John Babbage, and Babbage was actually the first to use it with iodine 131 labeled. And the Heidelberg group at the DKFZ, Uwe Haberkorn's group, used it with iodine 124 labeled, and you see that there is very early uptake 1 hour after injection and very good uptake even after some days. And if you are using iodine 131, you see that there is persisting uptake over a long time. And this is a feature which is predictive of a good therapeutic. Early uptake, rapid clearance, and long residence time in tumor. This is unfortunately often forgotten, especially of the new start-up companies. They are not thinking enough about our experience we have here. So we have performed in my center lutetium scans even after 4 weeks, not SPECT scans, of course, because activity is too low. But you see, even after 4 weeks, you see, the lutetium sitting in the metastases and nothing else. You see no normal organ. It's really, after this time, a very specific residence. If it comes to imaging and lymph node metastases, there is a very nice study published by Professor Samboglu from Freiburg in Germany, and they compared immunohistopathology with the imaging, and you see that you can really detect very small lesions, in this case a 2 millimeter metastasis stained here when it was seen on the MRI PET in this case, and we all know that the sensitivity of PET-CT is much better than the imaging based on MRI or CT scan. And these are some examples from my center where you very clearly see a 2.5 millimeter lymph node metastasis retrocrural behind the diaphragm, which would be on CT not mentioned at all because it's still in the normal size range. And this is something I found here during the last days, which reminded me that looking more closely can really show the truth. And I think what we are using with PSMA PET comes close to this. When you only look at the whole picture, you don't see the detail. But if you look at the detail, you see the letters which make the image up. A beautiful embassy from museum here from Harry, which I visited. So restaging where anatomic imaging might be normal. This is another example showing you a less than 2 millimeter lymph node in the external iliacal region here with a very convincing clearness and a very high inter-observer agreement. So if you show this image to 100 nuclear medicine physicians, they will all make the same diagnosis. If you show 100 CT scans to radiologists, you will probably end up with many different diagnoses. Okay, so proof of concept studies for the gallium-labeled and lutetium-labeled use of these compounds was actually based on our collaboration with Hans-Jürgen Wester in Munich, and we published our first results on PSMA INT in the Journal of Nuclear Medicine already 10 years ago, and then went further and labeled the compound with lutetium. And as already mentioned, the use of lutetium INT was the first use in the world on lutetium PSMA radioligand treatment. It was not 617. There were actually 7 months later in Heidelberg. They were earlier with the iodine, but with the lutetium, our group was really the first. And you see here lymph node metastases, and after treatment, they completely disappeared. When I left Bad Berka end of December 2019, we have studied more than 1,400 patients. Meanwhile, we are actually at more than 5,000 patients we have treated in our center. And aside from the single center experiences in Germany, there were then prospective randomized trials, RCTs, published in the Lancet, for example, by Michael Hoffman, who spent a lot of time, by the way, in Bad Berka. And I still remember the discussions with him. And he still gave a word of thanks to me for these discussions, which inspired some of these trials. And then, of course, a famous Vision trial from Novartis, which convincingly showed that lutetium PSA improves not only the response rate, but very important, the overall survival and the progression-free survival of the patients with better quality of life than standard of care alone. Based on these results, there were approval by EMA in December 22, and if I'm correct, in Taiwan, it was actually in February this year, it was approved. And this is a global survey. This is a slide I got from Andrew Scott, published in the Lancet Oncology in 2024, which shows you the use of lutetium PSMA. And I think at that time, there were no data available from Taiwan. But in the future, we will see a much greener world, so to say, more use of PSMA, dramatically more use. It is estimated or projected that the need in 2024 was 550,000 doses. And Casey has already spoken on the limitations of production, which we currently don't feel really. But this 550,000 doses are expected to double in the next 10 years, at least to double. So there will be 1 million cases, and the global lutetium production is sufficient for about 150 patients per year. So we have to do any effort to also increase lutetium and other radioisotope production. Now, lutetium is in the NCCN guidelines already since May 2022 for use after chemotherapy, and now also are for use before chemotherapy, which I will show you in a minute. But I would also like to stress that already in July 2023, so a few months after approval, we had the joint EANM and SNMMI procedure guideline, which was recently updated for the use of lutetium PSMA radioligand treatment, and I really recommend everyone to read it repeatedly. This is an overview of the clinical indications from the very early neoadjuvant use of PSMA, and we are going to perform a trial together with the University of Cologne next year. In Australia, there was a pilot trial called lutectomy on the use of lutetium PSMA, probably better terbium PSMA, for neoadjuvant for destroying micrometastases in high-risk lesion 9 and 10 cancer patients. And then we have the LUNA study and the PSMA addition and PSMA 4, which I will give you some information a little bit more in detail. The PSMA-4 was actually a randomized prospective multi-center trial with the aim of improving the rPFS, the radiologic progression-free survival. And when you compare it to RP, for example, enzalutamide or others in early metastatic castration-resistant pre-chemotherapy situation, you see that the rPSA was significantly improved in this patient group. So, and then we have one clinical example which shows that we have actually inhaled, I would say, this concept already 10 years prior. Namely, in February 2016, I have treated this colleague, a 62-year-old internist with hormone refractory adenocarcinoma, and he presented at my center in Bad Berka, and he refused chemotherapy because his wife had been dying of breast cancer, and he had seen all the adverse effects and said, I will never receive chemotherapy. He had locally recurrent disease, which you can see here. He had pelvic lymph node and disseminated bone metastasis, as also shown on this fluoride PET. And his biggest problem was actually that he had to give up his practice because of the very heavy pain he had from metastasis in the sacral region. So he could only stand, he could not sit anymore, and the doctor not sitting in front of his patients is a little bit difficult to handle his profession. And then we treated him just 3 cycles, and you see here the SPECT images after the first, second, and third treatment, and you see the very nice response which was confirmed on gallium imaging, and his PSA level went down from 356 to 0. And then we followed up this patient, right? First, he could restart his practice as a doctor and doing regular sports, and he loves dancing. So twice a week he goes to dancing and is feeling leading a completely normal life. And we followed him up in July 2017, 18, 19 in August, PSA always 0 in October 2020, and last time in August last year. And this is 9.5 years after start of PRT. So these cases, and there are a few around the world, show that you might be able to cure metastatic castration-resistant prostate cancer. If you ask a urologist how many patients you have cured with chemotherapy, his answer usually will be 0.0. There is no cure for mCRC, but probably we can cure even with lutetium these patients, which is not radiation alone, as I will explain later. Then there is a phase 3 trial, the PSMA addition trial, which was recently presented by Scott Tagawa at the ESMO Congress just 2 weeks ago. And this is a phase 3 trial combining lutetium PSMA radioligand therapy with ADT and RP in patients with hormone-sensitive cancer. So this is a first indication where lutetium PSMA is used in the hormone-sensitive situation. That's why it's called addition. And the primary endpoint, again, was met, as you can see here. So the progression-free, radiological progression-free survival was significantly longer than with the conventional treatment. And in summary, one can say that combining lutetium PSMA radioligand therapy in the PSMA positive cancers which are still hormone sensitive, So combining it with GnRH analogs, for example, or with enzalutamide or apalutamide can lead to statistically significant improvement in rPFS. And this was actually consistent across all subgroups. There was a positive trend in overall survival. However, one need more follow-up data to confirm this. So patient would live longer with the addition of PSMA radioligand therapy, and also PSA drop, PFS, progression-free survival, and so on, favors the use of radioligand treatment in combination. Safety findings were consistent with the known profile of lutetium PSMA 617 from the multi-center trial, with no unexpected concerns about combination and adverse effects, especially dry mouth, which can, by the way, very easily avoided if you give the patients, for example, polyglutamate to chew, which is available in multi-gummies for children in Italy. You can get it for a few dollars, and that very effectively can prevent dry mouth in patients. You cannot prevent, of course, fatigue and nausea in some patients, but this is very limited in effect and only present usually for a few hours, and can be also avoided if you give drugs like ondansetron, for example. And there were no clinically significant differences in time to worsening in HRQOL parameters and pain. These findings indicate that combining lutetium radioligand therapy with ADT and RP provides clinically meaningful benefit in patients with hormone-sensitive cancer. And this is a patient, also a colleague from Johns Hopkins, actually a personal friend of Marty Pompa, who also was hormone sensitive, and he was one of the first patients I treated already years ago in combination with ADT, and he is still doing very well and traveling all around the world and enjoying life. So this is something we should keep in mind. What is on the horizon? This is a very nice slide also from Michael Hoffman's group, showing you a summary what is coming from beta to alpha to Auger electrons on the one hand. So the radioisotope will play a very important role, but also radiosensitizers like PARP, and I will show you a different one, and also the combined use, as I already have shown you, with enzalutamide, abiraterone, or apalutamide, so the APs, and then something which is still in its infancy because we were up to now not really able to characterize the patients sufficiently, is combined immunotherapy. I also will give you another example. Dosimetry, I do not have really the time to discuss this in detail, might become important if you want to increase the dosage which you give to the patient, and then of course AI and or eye theranostics, especially in the imaging and dosimetry area. Now Auger and conversion electrons, Casey have already explained this to you, but the beta particles have a range of 10 to 1,000 cells, and the alpha particles of 5 to 10 cells, whereas the Auger just hit a single cell. So there is a range of just 0.5 micrometers, and that might enable to kill even very small or micrometastases. Our group at that time in Bad Berka was the first to use terbium-161 labeled to DOTA-TOC, and the group in Australia at Peter Mac have recently presented their data at ASCO of the first use of terbium-161 161 PSMA. And here is a rationale shown again. Terbium emits beta particles similar to lutetium, which also kill cells by crossfire. But on the other hand, there are, I think, Casey, it's probably mainly the conversion electrons, not so much the Auger, which was recently shown, which are very, very important to kill single cells due to the very short path lengths of just a few micrometers. And if you look at the preclinical data, these are from Christina Müller from the Paul Scherrer Institute in Switzerland, and she has very convincingly shown that terbium PSMA is much more effective in cell killing than lutetium PSMA, especially if it comes to small tumors, or for example, also the radiation dose to the nucleus itself, where terbium has dramatic advantages. Now, the trial scheme for this Violet trial, which was named to the physician Violet working at Peter Mac, unfortunately dying too early. These were patients with progressive mCRPC after one line or more of taxanes. They were all strongly PSMA positive with SUV max of 20 and no FTG discordancy. This is something Michael always do in clinical trial, I think, which is useful to exclude patients probably not profiting from the treatment, and then with a good ECOG stage. 36 patients, and the treatment was performed actually up to 6 cycles every 6 weeks with something which came up at our discussions in Bad Berka. I said we have to use the highest dose in the first treatment because there is the highest uptake and we can deliver probably the highest radiation dose and then decrease the activity. In the past, it was exactly the adverse. People increased the activity, but we have shown that this concept is probably better. And they decreased by 0.4 gigabecquerel per cycle with 3 dose levels of 4.4, 5.5, and 7.4 gigabecquerel giving to the patients. No significant dose-limiting toxicities. Most frequent lymphocytopenia, which I think is not really an adverse effect. I mean, you see the lymphocytes drop, but it has 0 clinical consequences. There are not more infections or anything like this. And also some cases of thrombocytopenia, probably due to the earlier use of docetaxel in these patients, which is really hammering down the bone marrow. And PSA response was PSA 50, so a drop by 50% was actually in 70%, and PSA 90 was 40%, which is very, very good if compared also to the VISION trial and the data from the VISION trial. Progression-free survival was median 9 months, which is also quite good, and a radiographic progression-free survival of 11 months. So very encouraging data, and these are some images. On the left, you see the gallium PET, and here's a quantitative SPECT-CT of this patient with quite good image quality also when you are using terbium-161, and this is a dosimetric SPECT-CT. And normal organ dosimetry is shown here, which shows no critical dose to kidneys or other organs. And the key takeaway points they made was first in human use of terbium across all cancer types in patients with progressive mCRPC, low rate of toxicity, and a good response to the treatment, which was actually better than the historical data which were used with lutetium. The data were just recently published in Lancet Oncology, as shown here by James Buteau, who is the first author. And a group in Germany, in Homburg-Saar, did dosimetry comparative between lutetium and terbium from Dr. Etzedin's group, and they found that actually the dose with the terbium is about 2.4-fold higher than with the lutetium. That's quite significant if you look at this. So combination therapies to enhance radiation effect is shown here. Of course, we can combine simply with external beam, or we can increase DNA damage, and we can inhibit DNA repair. We can combine with immune checkpoints inhibitors, or with kinase inhibitors, or we can also disrupt probably microtubules in combination with taxanes, which I all have used, which are mentioned here. I just will show you a very few examples. Upregulating target antigen, for example, with enzalutamide, was convincingly shown preclinical and also clinical, and I now use only, and you don't have to use the full dose of 160 milligram. 80 milligram is absolutely enough to achieve this effect of more pronounced PSMA expression. And there is a trial again from Peter Mack, which was, or the ENSA-P study, which was performed in different centers in Australia and reported increased progression-free survival and better PSA response than when used alone. And then we have invented, I would say, the use of thiamine antagonists called benfoxythiamine, which inhibits transcatolase. And just showing you one case, we also recently published a patient after docetaxel and enzalutamide receiving 4 cycles of lutetium, and you see the progressive disease. Since they stupidly used again docetaxel, because it's very well known if it does not work one time, it will not work the second time, but they still used it, and you see the very significant progression of lymph node metastasis and bone metastasis also in this patient. And then after 1 cycle combining BOT, benfoxythiamine, with radioligand therapy, he had a very nice response and lived more than 1 year. Then we have a very nice collaboration with the National University of Singapore, with Xinjing Zan's group, all very nice girls except some young boys here. And we just recently reported in Barcelona at the ENM Congress the synergistic anti-tumor efficacy of bimiralicib, or PQR309, which is a dual kinase inhibitor, using it in combination with lutetium and actinium treatment. And here are the preclinical data, very convincing data, which shows that we can significantly elevate DNA damage. We can suppress the PI3K-mTOR signaling pathway and glycolytic metabolism in these patients, and therefore enhance apoptosis also. So this might be a very interesting combination for the future, dual kinase inhibitors. Then radioligand therapy as vaccination. I just would like you to refer to this very good paper from the group from Montpellier in France, Jean-Pierre Pouget's group. They showed that their systemic effects may involve the immune system through the release of so-called DAMPs that are recognized by antigen-presenting cells, dendritic cells, and that present antigenic peptides to CD4 and CD8 T lymphocytes. I think this is a major effect of the so-called extreme or super responders, because you cannot explain the effects by radiation alone. This is a patient with liver metastasis. The mean overall survival of patients with liver metastasis is 2.9 months. 2.9 months. In such a patient, maybe less than 2 months. And you see after 3 cycles of lutetium, the liver gets smaller, all the lesions are disappearing. That can't be lutetium radiation alone. And I can show you more of these cases just as a potpourri here, before treatment and after one single cycle. You see all these so-called super responders with bone metastases, with liver metastases, with lymph node metastases. So there must be something else going on. And this is a patient very impressive after 4 cycles of a so-called super scan with PSMA achieving nearly complete remission of his disease. And then there are patients you do not need an MRI or CT to tell about the effect. This patient has actually a double vision because metastasis involves the nervus abducens and called a paralysis. And this is 16 hours after lutetium in combination with immune check blockade. And you see that the patient is laughing, is happy because he gained back his full vision and his eye movement as shown on these images. And we have published some of these cases in cancers just recently. This is another one with lymph node metastasis in the beginning, and then they did again radiation treatment and abiraterone, but a few months later the patient had full-blown disseminated bone metastases, and after one single treatment, as you can see here, the patient is a so-called super or extreme responder with a complete gone of all the disease and the normal PSA level. And just a few days ago, there appeared a paper in Nature that SARS-CoV-2 mRNA vaccines sensitize tumors to immune checkpoint blockade. And this is exactly the same principle which I have shown you, that probably also radioligand therapy causes these stems and they are really stimulating the immune system. I think we have to have a closer look into these issues. Then alpha emitters, I will just shortly mention here. You have heard already and seen these very impressive images from Heidelberg with a complete remission after failure of lutetium therapy. I call it the second revolution in prostate cancer. And we were using first the combination of lutetium in combination with actinium, which I call tandem treatment, which might be able to cause remission of the disease even in patients progressing under lutetium. And just mentioning the actinium-225 Worms Act study, which was published in Lancet Oncology and convincingly confirmed that actinium is of great clinical value. There are now several industries like Race Bio and Telix, for example, and Advancel using also lead-212. You have heard already in the previous presentation. And we have used this in combination with bimiralicib in a very heavily pretreated patients. And you see that there is a response also with lead-212, which can break resistance probably to lutetium. So the future progress will be, as we discussed already, with new radioisotopes and new production ways. For example, you mentioned also the Rhodotron and E-LINAC. I see great potential here. And then, of course, in radiopharmaceuticals, new small molecules, new targets, and then in the scanner technology, which will enable us to study actually 60 to 80 patients, like I have already seen in China in some centers per day, not per week. And this is necessary. And this is the most exciting news at the very end of my lecture. If you look at radioiodine, you have SUVs of up to 1,000 in some metastases. And 1,000 SUV and a long residence time in tumor means the tumor gets doses of 300, 400, sometimes even 500 gray, which kills every life. There is no resistance to radiation in this range of radiation. And then if you look, for example, to PSMA or somatostatin receptor, we get in some patients 100, sometimes 150, or I had a patient with 280 SUV in DOTA-TOC, but it's still a range lower than with the radioiodine. And if you look at FAPI, for example, we are speaking about SUVs of 10 or 15, and usually a very short residence time. So the news is that, and this is also a Nature paper, that covalent targeted radioligands potentiate radionuclide therapy because we have this ligand and this covalent warhead, which not only increases the uptake, as you can see here. This is SF with the warhead suffix, and this is a normal FAPI. So the uptake is higher, but what is much more important in my view is that the residence time in the tumor is much longer. And the dose to the tumor is defined by the area under the curve. So this is what we are using today. This is what we are going to use in the near future. So we can significantly increase the tumor dose, and in animals it works already very nice. You have a cure in these animals, and the good news is that it also works with PSMA. So this is what we are using today, and this is what we are going to use in the future, and this is why I entitled my lecture, Is Cure Possible? Probably with these new compounds covalently bound and some radiosensitizers we might be able to achieve this. And what is needed for the future, of course, is shown here. Precise information by genetic combos, interdisciplinary collaboration, serinostics or iserinostics, and training. And that's why I'm also the president of the ICPO. I do not have time to go into detail here, but there are 4 different pillars for doctors, for physicists, for radiochemists, and for patients and nursing. And we have more than 50 hours of online material. If you scan this with your iPhone, you will get all the information. We are now reaching 50 centers in December. Now we will probably be over 50 centers. And next year we have the aim of 100 centers worldwide, and it would be very nice if Taiwan is joining the gang. Yeah, so we will have the next Radiomolecular Precision Oncology ICPO Theranostics Virtual Summit in November next year, probably a little bit to go there, but you can mark already your calendar. And this is my last slide. I would like to invite you all to the 8th Theranostics World Congress in wonderful Cape Town, South Africa, end of January next year. Thank you very much for your attention.
Thank you, Professor Baum, for your inspiring talk. And on behalf of our society, we're going to just honored to present you as the certificate of appreciation.